Welcome everyone to the Disaster Response Collaborative's Fireside Chat for today, November 18th. We'll be talking about mental and behavioral health, specifically the management of pediatric PTSD and comorbid symptoms within the framework of disaster response. Before we get started, our acknowledgement says the Pediatric Pandemic Network, as well as DRC, is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The content presented today is that of the authors, does not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. We are pleased to offer continuing education credits for today's session. So this will be for physicians, nurses, and social workers. A couple of things down here at the bottom. You will need to attend the entire live session. We'll need to make sure that the session evaluation is completed, and that will be the QR code and the link for that session evaluation will be at the end of today's session. And if you are using someone else's registration, this happens a lot. If someone forwarded you their registration for today's session, go ahead and put your name and institution in the chat. And you can do that as well and go ahead and introduce yourself. And with that, I will hand it over to our esteemed speakers today, Dr. Kodish and Dr. Sadinajad. Thank you.
All right. Well, hello. My name's Ian Kodish. I'm at Seattle Children's Hospital, and work as medical director on the inpatient consultation liaison service affiliated here with the University of Washington. I'm also a member of the Pediatric Pandemic Network in the behavioral health domain and have worked with Mo on some projects on dissemination and communication. And I'm looking forward to connecting about how we can do better with regard to supporting kids in the emergency department who have struggled with trauma and are coping with disaster reactivity.
Thanks, Ian. I'm Mo Saidinejad. I'm a pediatric emergency physician. I work at Harbor UCLA in Los Angeles. I'm a clinical professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. And locally, I also serve as the Institute Director for the Institute for Health Services and Outcomes Research at the Lundquist Institute, which is attached to my hospital at Harbor UCLA. I am also a domain co-lead for the communications core of the PPN, as well as a member of the mental health domain of the PPN. I also have many other hats, including the EMS for Children's program, as well as PCARN. And basically what we're going to do today, I am going to be the interviewer of Dr. Kodish. I am the learner here myself, and he is the subject matter expert. So we're going to do this sort of like a conversation / podcasty type of format. And hopefully at the end of this, you guys will come away with some really important information about how children are affected in post-disasters, as well as how to deal with them, both at the time as well as longitudinally. Next slide. So again, this is a matter of what I just talked about, objectives. We're going to discuss how to recognize PTSD and symptoms that might not be so obvious in children, talking about management strategies for PTSD, how to talk to children about loss and grief, and how PTSD can become a lifelong kind of a problem after the patients are exposed to it initially. So next. So the title of this topic is Management of Pediatric PTSD and Comorbid Symptoms within the Framework of Disaster Response. Next. So I just wanted to start with some interesting forethought. So one of the challenges that we're dealing with here is what we can see and what we can't see. We as clinicians are pretty used to physical injuries. We can see them, we can treat them, but emotional injuries, they can often be extensive, but it is very hard to see them. Sometimes they're not visible at all. And emotional trauma not only is a consideration at the time where you're dealing even with physical problems, but you have to think about short-term, long-term, and lifelong term concerns that are faced by children in the aftermath of a disaster. Isn't that true, Ian?
Yes. So what we're hoping to do today is try to talk about how a trauma-informed approach in the emergency department can really be structured to best enhance a child's resiliency and support that long-term recovery after a disaster. And I think this room is filled with folks who have helped to care for traumatized youth in some settings, but in emergency department settings in particular, there is a lot going on. The waiting room is chaotic, beds can be full, children can be screaming. And what we're hoping to do today is equip you with more insight and tools to try to address these unseen wounds of disaster trauma within that high-pressured emergency department environment.
Can you share with us some of the data, some of the statistics about the impact of trauma events in children?
Yeah, so when we think about how children respond to severe trauma, the epidemiology shows that about 1 out of every 6 kids who experience severe traumatic events will eventually develop post-traumatic stress disorder. And about a third of those who develop PTSD will have sustained symptoms. So I think this is a mixed bag here where symptoms can really be profoundly impactful on both the brain and behavior. But it also highlights how resilient kids are and how powerful resiliency is, and how that's actually a more common response than a pathological response. What we do see is that the most detrimental impacts of trauma seems to come from what we might expect, where there's more severity in terms of the threats to life, or more severe disruptions in displacement, and interpersonal violence of that nature tends to have a more profound impact in terms of persisting symptoms, as well as the notion that there's a cumulative impact of traumatic events. And so each of those continues to heighten the risk of psychopathology moving forward in the child's life. Um, in general, females are 2 to 3 times more likely to develop PTSD, and that's after accounting for differences in traumatic exposures. And then thinking also about the parents and their relationship, their reaction can play a big role here in terms of supporting resiliency versus contributing to some susceptibility. And one of those aspects, even beyond parents, is the social supports and the community supports that the child and the family have. And that, I think, really stresses the importance of connectedness in recovery. And so thinking about ways that we can implement that as a touch point from the emergency department, I think, can go a long way. And then back to the child, even just the type of responses that you see after trauma can be associated with PTSD. So kids who tend to be more reactive with anger reactivity, or exhibit more negative self-appraisals, or exhibit a lot of avoidance symptoms, tend to be associated then with higher rates of PTSD, as opposed to that resiliency picture that a lot of kids exhibit.
Yeah, thanks. Can you move to the next slide, guys? And then probably next one after that. So yeah, this is kind of interesting because at the same time, we need to also talk about stressors and how much they actually affect children in the aftermath of a disaster. And one of the things I was thinking about, for example, is what is the dose? Like how much exposure to the trauma did a child have? What was the proximity to the traumatic event? And how severe and how prolonged that was? We have to think about, was this, for example, a situation where the child lost their house or lost a loved one or lost a neighbor or lost their school? Or was this just something that was a few streets down and was more isolated? So that dose is an important piece. Also, we have to think about how this is going to continue to affect the child. And we know children, depending on whatever age group they are, they may have some challenges even putting their emotions into words. And a lot of times they may not even recognize that what they're feeling and the difference that they're feeling is related to the fact that they're exposed to an immediate trauma. Children, again, depending on age, may exhibit things like avoidance. Sometimes may just hope that, hey, it was just all a dream. I'm going to wake up and everything's back to normal. Some of the older kids might exhibit signs of social anxiety, withdrawal, and then in severe cases, this can also technically become a cognitive impact issue where they start not being able to process things normally anymore and things like that. So how do we define PTSD and its common symptoms? If we were to actually identify what is actually the parameters of a PTSD, what would you say? And we can go to the next slide, please.
Well, I would grab my DSM book here. And according to that, thinking about the impact that kids sustain on this, the diagnosis of PTSD is essentially based on some exposure to severe trauma and threat. That can be either of severe violence or life-threatening experiences, and can be either directly experienced by that child or known to be experienced by somebody who that child is really close to, so typically a parent. I also want to comment, though, because of the audience here, that PTSD can occur through indirect exposures from healthcare workers as well. And that can obviously be more profound with more severe distress that we might witness here. And so I don't want to ignore the impact on systems folks that are beyond just the direct impact of the child here as well. But in terms of diagnosing those specific symptoms, in addition to that exposure, then we tend to focus on 4 domains of symptoms. The first being intrusion type symptoms or re-experiencing symptoms. So most commonly, very specifically, kids struggle with nightmares. That essentially disrupts sleep, but it also can be really distressing. And as you had mentioned, sometimes kids don't even have the cognitive capacity to kind of recognize what that content of the nightmare is, but it sure can be distressing. And then even during the day, flashbacks, intrusive thoughts and memories, to the point that sometimes coping can result in dissociative types of symptoms where the person experiences depersonalization or derealization, or that intrusion can feel so palpable that they just have prolonged distress when reminded of the experience. So that amplified response and how this trauma continues to invade the cognitions of kids is an important component here. Then there's also the avoidance domain here, and that's a pretty common response where any reminders of the trauma are going to feel pretty triggering. And so people do a lot to avoid that, and that might be avoiding locations or people or activities that are reminders. And as we'll see, that can have downstream consequences for actually symptoms persisting. And then symptoms can also become a little bit more entrenched in terms of affecting mood, affecting how people view themselves, having decreased interest in enjoyable activities, and even viewing yourself as someone who is not worthy, who feels guilty, who feels like it was their responsibility. And then last domain is what we call hyperarousal, and that's what you might see with the excessive startle reflex when they hear a bump, hypervigilance, feeling like you're always needing to scan your environment, but also some reactivity of just impulsive irritability, distractibility, sleep disturbance, and sometimes having reckless, dangerous behaviors as a consequence of the PTSD.
Yeah, thanks so much for that. And if we can go next slide. And sometimes these symptoms may actually be pretty subtle, and sometimes they may not even be recognizable as being part of these. For example, from the cognitive side, it might simply be issues related to concentration. It might be additional sense of fear. It might be even overblowing it into catastrophizing it as a lot more than it actually was. Kids also sometimes end up having struggles with misinterpreting social cues, trying to kind of understand what somebody's body language is saying, what somebody's actual words are meaning. Kids can also, like adults, experience excessive guilt. They can also have the other end of the spectrum, which is complete emotional numbing. And from the behavioral standpoint, they can experience regression in their way of acting. They can experience nocturnal enuresis. They can have physical discomfort. And, a kid, for example, who has been really doing well before the disaster with their bedtime routines and knowing what time to go to bed, all of a sudden they're not in their house anymore and they still need to go to bed. They forget that they need to brush their teeth. So you have to remind them of basic things that they used to do really well. And sometimes they also, this is another part that in the ED we have to deal with, is somatization. You come in with these vague physical complaints and we start working them up as if it was really medical, but all along it was basically something that's more behavioral and mental health. Social wise, same thing. The kids, as you mentioned, Ian, they may over and over play this trauma out in their head, which can during nightmares and also when they're awake too. They have also the chance of having a complete alteration of their behavior. They may suddenly become very inhibited or become very disinhibited at the same time. In the more complex case, and we're probably going to talk about this more with you, Ian, later, but with complex PTSD, you have this affective dysregulation and exacerbation of the sense of negative self-concept, especially in those who are more prone to it. And then it also affects your interpersonal relationship and causes significant social disruption. So with all of this, Ian, I think that I am kind of convinced that there is something really neurochemically is going on in the brain, that there's something happens that really requires your expertise to explain to us what has actually happened to the neurochemistry of a child who is experiencing these kind of traumatic events. What happens in their brain? And you can go to the next slide.
Yeah. Yeah, and I guess I forgot that in my former life, I did neuroscience PhD at University of Illinois, mostly focused on experienced induced brain plasticity. So I actually view things much more from like an anatomic synaptic kind of level. I think there's more and more data over time that PTSD is interfacing with synaptic functioning in a very meaningful way. So we've known for a while that stress and abnormal stress responses in PTSD affects things like the hypothalamic pituitary axis and the stress response with cortisol regulation. And I think it's pretty profound, even though it's been known for about 20 years now, that the impact of trauma at a very early age can actually leave a genetic imprint, literally on DNA, by attaching methyl groups that then can carry forward even into adulthood to affect how we respond to stress by physically actually blocking the transcription of receptors that regulate your stress reactivity here. I think that that's a profound statement of how impactful some of these experiences are, that they are carried forward even within the way that our DNA is transcribed over time. And one way of viewing that is actually that this methylation or epigenetic process happens with all of us and is sort of a sign of aging. And it's interesting, there's more and more data that as a consequence of trauma, the brain starts to exhibit accelerated aging processes on a number of levels, including in synaptic development. So when now jumping to how kids' brains function after PTSD, why are they exhibiting some of these behavioral differences? If you put them in fMRI scanners and try to evaluate different parts of the brain, there's a clear impact that the amygdala regions, or these threat detection regions of the brain, are more active, that they are essentially unchecked. And then conversely, that there are hypoactivity in these more executive prefrontal regions of the brain. And beyond that, within these regions, that relationship gets altered. And so prefrontal areas are not able to modulate that threat detection system nearly as well. Not only can that, impact your reactivity when you're presented with something stressful, but it also even affects mundane social interactions, so that kids actually can interpret benign social cues as overly hostile, overly negative, and then also impact other cognitive functions that we see with PTSD, like working memory function, impulse control, and even the way that they appraise themselves. So how do these functional problems arise? Well, taking even one step deeper with regard to synaptic plasticity, I think it's really interesting to think about how typical development goes and then what the impacts are as a result of PTSD. So if you will allow me to take you through neuroplasticity 101 here, in normal development, humans way overproduce synapses, and then we prune them to selectively modulate how those networks are going to connect effectively. And that happens in all the parts of the brain. Optimally, that's going to be attuned with our environment to make, for instance, our visual cortex work well because we're getting visual input early in the time that our brain expects it to. So what the brain has done is cleverly developed what we call these sensitive periods, where areas of the brain are really primed to respond to certain modalities of input that area of the brain supports. So if you miss visual input after this sensitive period has moved on from primary visual cortex, you will not have the plasticity to elaborate these regions. And really what this plasticity does is it prunes so much and then kind of makes that region functional for that specific modality, but it leaves it a little less plastic, a little less adaptable over time. And then that sort of wave of plasticity goes to more and more highly integrative regions, eventually culminating in the prefrontal areas, the most integrative regions of the brain in adolescence. So if we go to the next slides, these are depicted a little bit here. So this is in normal childhood development across age in looking at cortical volumes in different parts of the brain. And the yellow is essentially unpruned areas. And then the blue is increasingly pruned areas. And if you see over age, essentially we are eventually pruning even the most complex areas of our brain. And in the next slide, they compiled this into a little bit of a video here, where it essentially shows this dynamic wave where the pruning continues from essentially a back to front, but really a primal to more integrative region in terms of the pruning. Then the next slide shows that meanwhile, even these cortical areas, they're going on in sort of this concert of pruning subcortically in the amygdala. There's also its own developmental attunement to emotional experiences that over time can influence how its subnuclei then both develop as well as connect to these prefrontal regions. So you might guess that as a consequence of severe trauma, this concert attunement is really going to be affected, and that can dramatically shift the timing of some of these intersections that the brain was designed to do evolutionarily over and over again in a way that really alters that developmental trajectory. So cross-sectional studies have shown that in brains of youth who have PTSD, you actually see cortical thickness changes, especially in prefrontal areas like these ventromedial prefrontal areas right in the front of the brain, and in anterocingulate cortices, which evaluate threat and more cognitively rather than primally, and that contributes to these problems with threat detection. But it also is kind of a signal that these accelerated brain changes through PTSD are really global. And the thought is that they actually have accelerated pruning, that this developmental trajectory of overproduction and then synapse elimination is actually too advanced, if you will, and contributes to actually acceleration of the age-related declines in cortical activity, which then might lead to that clinical picture. And interestingly, there's been more longitudinal studies that kids who have actually remitted from PTSD actually show regrowth in these ventromedial prefrontal cortical areas. So there's an expansion with resiliency, with recovery that I think is really important. Interestingly, even puberty tends to come on quicker in kids after severe trauma. So these evolutionarily built timing evolutions can really go haywire essentially as a result of the profound impact of this maladaptive experience instead of helpful experiences. So really, Well, I guess to the next slide here, this shows a little bit of this disconnect between our prefrontal areas and our amygdala, that regulation is essentially off, and you see hypoactivity in prefrontal areas and hyperactivity in the amygdala, so that they're not jiving here. And so to get better, next slide cuts to the chase a little bit here. We really want to drive that neuroplasticity again. You really have to engage the child, and that's a component of just life, and getting back to normal activities is hugely important, not only psychologically, but actually neuroanatomically, to drive that neuroplasticity, to rework this relearning of a threat detection in your environment, and to have more adaptive responses, as opposed to the avoidance symptoms that might take you further away from those experiences, or if anything, reinforce this notion that it's sort of too hot to experience. And so you cannot exhibit that neuroplasticity in a way that is going to eventually re-regulate some of these regions. And so I think what we're seeing here is actually trauma impacting this developmental neurotrajectory in a lot of different dimensions that can really be impactful, both on a chemical level, but even more so on a synaptic and anatomic level.
Yeah, is there a next slide too?
Yeah, and so these components, of like exposure therapy, we think that kids get better as a result of that because you are actually driving new learning. And it's interesting, if a kid goes to exposure, or adult goes to exposure therapy, and they just try to dissociate, and they try to not really attend to the stimulus of exposure and kind of count or close your eyes, even if you're kind of exposed, it doesn't work. You actually need to be exposed. You need to drive that relearning to allow the brain to make these changes, and to use the neurotrophic factors and the potentiation of reconnecting circuits in a way that can drive recovery here.
This is both really, really amazing and scary at the same time. And I'm just thinking about the more and more complex lives have become, and more, at least small doses of trauma after trauma, and then bigger doses of trauma. I'm just wondering sustainability of this in a poor child's brain. Like, how is this going to look like in a little bit? I'm going to go to the next slide. And I wanted to kind of start talking a little bit about what is my bread and butter of what we do, especially in the emergency department, talking about management approaches and what clinicians can do to better understand and manage this kind of heterogeneous and not very simple phenomenon of PTSD, and especially in the aftermath of bigger disaster. And recognizing the fact that, there are multiple elements that are all interplayed. And as you just heard from Ian, the neurochemistry of all of this is insane. And it's just a wonder how more things don't go wrong, considering all these different opportunities for things to misfire. But I would say that the first thing is, when we're dealing with the evaluation of it, as I said before, dosed exposure to the trauma, it is good to basically try to find out from the child in their own words what they feel has happened to them. And of course, that is never enough. You do have to still get perspective from the family, try to figure out from the child, talking to the family about the disaster itself, how close the child was to witnessing some of the effects of trauma. Did they actually witness somebody die in front of them? Did they witness their house burning down, losing their pets, and all of those things from the perspective of the adult caregiver? And also thinking about specific children and ongoing sensor or stressors that can complicate the recovery. For example, if a child has a family member who lives with them who has device use needs or has special healthcare needs, and now their disruption is affecting the child too, because any person who is dependent on technology and dependent on normal everyday life all of a sudden loses those in a disaster that can also affect the child. Even the child themselves may not be the one that's experiencing this. We also have to think about the child themselves. Is this a child who's neurodivergent or has otherwise, as Ian mentioned, have some sort of predisposition to more anger and more outbursts, which this can be significantly exacerbated. Even if they're not exhibiting at the moment, they're at risk for, as we're mentioning, as you relive this trauma in waves, you have the capability of having this come up later. And also being able to identify those who are really seriously affected by this trauma and making sure to do our best to get timely referral and support to help these children with their risk. The next slide was going to show how the American Academy of Pediatrics has some really amazing resources that help clinicians understand the need of children. There is this one clinical report, the QR code to the left low is the one that shows that article that was published in Pediatrics in 2015, still very, very relevant. And a good group of our friends were all part of the writing group. And then this really nice comprehensive resource. I usually don't like to give out like long, many pages worth of resources because it's hard to sift through them. But this Helping Children Cope and Adjust After a Disaster is a really amazing resource. It's broken down by parts and has various resources embedded in it. And I think this is a really good resource that the American Academy of Pediatrics has, that I was hoping that you guys, if you were going to take one or two things from this session today, to think of these resources as how you can go ahead and navigate children that you receive who are exposed to disaster and need coping skills. So moving on to the next slide, I also wanted to ask you, Ian, about what are best approaches to how we actually treat the patient who has suffered PTSD, and recognizing that children of different ages may need some tailored or some customized approach that is best suited for their age. Do you have any advice for that?
Yeah, I mean, I think first I just want to acknowledge that I think having them in a safe setting and provide for their primary needs is kind of the ultimate priority here. But if we think about the therapeutic approach that tends to be most helpful here, what we typically jump to in our minds is trauma-focused cognitive behavioral therapy. But as you said, younger kids don't really have the cognitive capacity to try to challenge some of their cognitions, much less even sometimes label their emotions. And so structuring this in a developmental perspective, I do think is important here. And essentially what you tend to think about is that with younger children, you want to more incorporate parents into the program here. And that can come from things like this parent-child interaction training, where the parent gets little support from feedback during interactions with their child, but also supporting them with, relaxation skills, with ways to stay grounded, with ways just to identify emotions and then try to regulate them a bit. So conjoint sessions with the parent, I think can be really helpful to reestablish that family bond, which sometimes gets lost in avoidance symptoms or trauma, or, that stiffening of affective responsivity. But it also can keep a lens on how symptoms evolve over time, keep the kid, engaging in the strategies that have been implemented, and think about how do we deal with things like suicidal ideation? That's obviously going to be an important parent component here. But then older teens, we do tend to dig into their cognitions a little bit more. And the thought is that they have greater capacity to work on decreasing the intensity, decreasing the heat of their experiences. So you can challenge their negative cognitions in what we do more traditional cognitive behavioral therapy. But then a trauma narrative is what we try to establish, where the child and the youth can get their facts down a little bit and to establish a sequence of events and have that structure so that it's not just that completely dizzying experience. There's actually some structure to it that they can label, that they can then attach emotional experiences to various steps of that experience. And then you can start to listen for irrational thoughts and potentially misattributions of blame to kind of question, are there other ways of thinking about this? And then hopefully to eventually come up with a place where not only are they comfortable with labeling the past, but looking forward to the future and what is their goal, and can they be vulnerable in establishing that in a way that can actually get them back into the playing field of normal function here, get them back into school, get them back to address the things that are valuable to them in life moving forward here. So helping to organize that memory into a life event rather than an ongoing threat. But if we link back to the neuroscience of it, I think what we're doing here is helping them get out of that threat detection network and into more cognitive functionings like these prefrontal executive functionings. And so I think that's a good method to think about how we can drive some of these therapeutic approaches to get kids less stuck with the impact of these symptoms. But then next slide, we also think about the medication approaches here. And this one, I feel a little bit more humble. I think that was the past slide, not the next one. Yeah. That I think really, I just want to caution that there's not great data in kids for the use of medications to target PTSD. So it's pretty tempting to think about SSRIs because they are approved for OCD and for depression in teenagers, but there are actually no SSRIs approved specifically for anxiety disorders in youth. There is duloxetine and SNRI that's approved for generalized anxiety, but data are mixed in terms of whether an SSRI is really going to be helpful for these kids. So I don't think it makes sense to just, think that that's going to be sufficient for them. And I would really emphasize the importance, number one, of family support and of therapy. But if we did need to go down the medication route, really the focus has shifted to thinking about the devastating impact that sleep impairments have on these kids. And even though that seems pretty small compared to all of these symptoms, it really is profoundly impactful when kids are not sleeping, not getting their rest, whether they have PTSD or not. But when that is severely disrupted, that then becomes a big target of intervention. So more and more so, we're thinking about these adrenergic modulators like prazosin, which has some evidence for decreasing those intrusive symptoms in the middle of the night, the re-experiencing, the nightmares, and to facilitate sleep quality. So that's a pretty common approach, but you also do tend to run into hypotension and dizziness, especially in kids. So that needs to be monitored pretty carefully. But even if sleep is optimized and you're still getting a lot of hypervigilance symptoms, then within that adrenergic modulation, we often use guanfacine, which is sort of a cousin of clonidine, an alpha-2 antagonist for these persisting symptoms. And we have found that that can be helpful to reduce that hypervigilance, the reactivity, and sometimes the agitation that kids often tend to exhibit here. I would say conversely, we really do try to shy away from like the benzodiazepine class of medications in kids with trauma. That does tend to impair memory processing more. It can, result in disinhibition instead of improvement in behavioral regulation. And some kids just get really antsy because it sort of compromises their own sense of being in control. And then antipsychotics are also a consideration here, especially if kids are dissociating or exhibiting a lot of perceptual abnormalities. But again, the data is not very supportive, and kids with PTSD already run the risk of having higher medical sequelae like risk of diabetes and cardiovascular complications. So unless the psychotic symptoms are super severe or agitation feels unmanageable, we also tend to avoid antipsychotic classes of medications.
Yeah. So thanks for that. We'll go to the next slide. And I just kind of wanted to quickly go over what ED clinicians should consider when they're dealing with a child who's affected by a trauma. So the most important thing to realize, of course, is that emergency department by itself is not a really good environment. There is issues with chaos, there's noise, lightning. It's a high pressure environment, especially after a disaster. There's all kinds of crazy stuff going on. There's always a lack of adequate resources and staffing and rooms and places to see patients. We also have to balance the fact that we're very familiar, as I said before, with managing medical problems, but we're not so well versed with how emergency department clinicians deal with the mental and behavioral component of a post-disaster event. So some of these children, like I said, they present with vague medical symptoms, and we work them up because it's so vague, we don't know what it is, so we work up everything. But the more vague and the more workup everything needed, the more it's probably not even medical. So that is kind of one of the things that we're struggling with. It's also difficult for a child to feel safe in an environment where potentially half of their family members aren't there. Somebody may have even been injured or worse, died. It's cold, it is unfriendly, it's a confined space, and it's not an ideal place itself. So one of the things we think about is helping them with trying to keep the family structure together as much as possible. We want to make sure that we understand that the clinician themselves can also potentially suffer from compassion fatigue after seeing over and over a case of really bad trauma. They themselves become kind of numb, and they have a hard time, being objective about trying to care for mental behavioral health needs of children. So some of the ways to mitigate this, I was thinking, what do you suggest, Ian, as way to mitigate and despite the challenges we have in the ED environment, how can we do better to make sure that we address this need of children despite our environmental restrictions?
Yeah, and I think some of these ideas that I have down, might not apply to every emergency department. So I want to qualify that here. But I think, thinking about it from a couple of angles. So one, being just the systems issues, is there any way to create the environment to be a little bit more nurturing? So softer lighting spaces, having warm blankets, having access to snacks or distracting activities, even having access to sunlight, especially with patients who might unfortunately be boarding in those spaces, I think goes a very long way to helping them cope with the demands of that environment. And then I know most EDs are already doing this, but really making an effort to try to offer quiet space and to limit overcrowding and to reduce wait times if at all possible. And then when that's not possible, inevitably there are going to be a lot of handoffs. And so having a warm handoff, I think, can go a long way towards yet another person who's introducing themselves to a kid who really has no desire to reveal themselves in terms of their vulnerability is important. And, when possible, then staffing with consistent staffing, as well as, potentially implementing resources right there in the emergency department, with tips from SAMHSA or with other approaches that can be used just in time. I think you need to kind of get creative at figuring out ways to meet the child where they're at and come up with some strategies, both clinically in addition to with the systems here. And then also just the form of communication, I think, can be optimized a little bit. So what are they expecting here? And if you can introduce kind of a timeline of a schedule or structure of expectancies, I think that can help them feel a little bit more grounded, to give them some agency in the matter. And I mean, this applies to everybody, but if you can offer them a little bit of choice in terms of the timing of things, in terms of any preferences that are feasible, in terms of the order of interventions, that can give them a sense that they are actually being listened to and engaged here. Conversely, I think sometimes just giving them the sense that they're important by going slow and during the interview to allow some silence and to engage in unhurried conversations and to use a reflective style, and open questions, which goes against the philosophy of the emergency department that we need to get action here, very action oriented. What's the deal? Are we cutting it out or not? Kind of an approach. I think that can do you a disservice in terms of really giving the kid a sense of a platform of safety in order to communicate here. And then, more broadly, are we thinking about trauma-informed care, cultural sensitivity? Do we have communication barriers here that should be addressed? To really view them as, unique individuals rather than somebody who's coming in here with problems. And, it comes down to, I would also suggest just trying to be as human as you can in that room. I think of experiences myself in the healthcare system where the provider's staring at the computer, being frustrated about this or that, or, asking questions seemingly in a rote fashion to kind of check the boxes. But I think these kids in particular could really benefit from good eye contact, from reflective style, and to really validate that you do have a genuine curiosity in supporting them. And then jumping to how can you help them moving forward, I think needing to keep an eye on safety is sort of the number one priority. A lot of these kids do struggle with suicidality, and there is something reassuring, even though it's hard to ask some of these questions, that we're considering safety as the highest priority. but also then trying to do as best you can to have tighter follow-up plans, appointments or backup contacts if things fall through, so case management. And then to really just reinforce that even after they leave, we are rooting for them essentially, and we are here, and we really want to reinforce that help-seeking instinct. So even if they didn't have the funnest time in the emergency department, and I don't want them to have the funnest time, but we want them to come back when needed. And so sending that message, I think, is also important to convey a sense of hope moving forward.
Yeah, thank you so much. This is really a very nice way of summarizing all of these things, because a lot of what you said are actually really nicely generalizable to multiple different post-disaster scenarios in the ER. Can we go to the next slide? And then one more after that. Yeah. So I want to talk a little bit about just closing the loop on what you just said. What we basically need to focus on. We have to also remember that these children who come to the ER, and oftentimes they end up spending extended period of time, more than a day. We need to prioritize their regular needs. We can't forget that they need to eat, they need to drink, they need to go to the bathroom, they need to be outside. They need to also have proper clothing, all of those basic needs not to be forgotten. We also should concentrate on anything that is a family focused strategy, allowing children to express their emotions, trying to come up with creative outlets for them, activities that they can do, try to limit their exposure to the media. I mean, there's other crazy depiction of violence and trauma that is very vividly in the media, and the kids kind of are easily impressionable and they get affected by that. We also have to make sure that we do our best to create that sense of community. Like, for example, the LA fires recently, there were whole communities lost. The school is lost, the library is lost, grocery store is lost, and the whole sense of community is lost. So finding a way to see if people can connect with each other, members of the same community, as well as enhancing self-efficacy, allowing people to set their own goals and allowing them to create their own activities and structures for themselves. And also identifying, really the important thing is identifying what sort of intervention they need. Something that is appropriate for a mild trauma, like a mild exposure that is not really affecting the child too much, might be accessible with a simple psychological first aid, which we can, as emergency clinicians, do, versus somebody who has a much bigger need for something a lot more significant, that is like a trauma-focused cognitive behavioral therapy, TFCBT, being able to determine who basically needs what. And when we go to the next slide, what are some less obvious things that we should consider about? And also, what are some things that we're going to tell people to just not do? What are some of the don'ts?
Yeah, I think what we see sometimes is parents fall into some of these traps of really wanting to do well for their kids here, and same with clinicians here. And so sometimes in that effort, we're actually sort of not really supporting the child as well as we think. So saying things like, at least we're safe, or it could have been worse, even though that feels like you're trying to reassure them, in some ways that can minimize or dismiss their feelings. So having more of a validating and reflective approach and helping them just label their feelings and reflect that to them, I think is much more important than trying to solve the feelings problem in the moment here. And similarly, trying to force them to talk before they're ready. It's very natural to have avoidance as a coping mechanism. And even though I speak to the dangers of that over a long period of time, shortly after a trauma, there's actually some risk of, heightened dysregulation if you want to try to make them too vulnerable too quickly here. So really giving them the sense that you're available to listen when they are ready, and trying to pay attention for the subtle cues when they might want to talk, and even through modalities that might feel a little bit easier of communicating, like through play or through drawing, can really be more effective. And then, don't try not to at least convey your own sense of anxiety. I mean, I think parents need to be real, and they need to convey that, this can be disturbing to them. But in terms of exhibiting their own functioning, trying to exhibit a sense of resilience yourself can go a long way towards modeling with kids. And again, you had mentioned the media reports. I think you want to be matter of fact and to give them just enough information to have a sense of what's going on without exhibiting a lot of the graphic details that can actually be destabilizing. And then there's also a temptation, particularly when you're getting your kid to kind of function a little bit more adaptively. Well, hey, if they want to take care of the little siblings, that seems great. But there can be a slippery slope into more parentification where they actually then feel compelled to support the feelings of the parent. And so letting the kid be a kid and giving them the space to be a kid and the space to play, I think is also really important to stay attuned to. And then there's more on the next slide here. That parents need to take care of themselves, and so being sure that they're getting their own mental health addressed, and not ignoring the fact that some of these can be late evolving kinds of symptoms here. So to stay attuned that just because you're a month out and the kid seems to be doing well, it's still very possible that some of these things are going to manifest in the future. Trying not to make promises that you can't keep, that this will never happen again, or some false reassurance. That can be pitfalls if you do need to be re-exposed to another traumatic event. And I think, most importantly over time, to not really overly accommodate the child. The separation anxiety is going to be a natural, immediate response. And that will be appropriate to support the kid and to kind of normalize some regressive behaviors. But you really want to think about a recovery path here where we can get them back engaged in connections with families and friends and back in community functioning. So keeping them isolated or trying to say it's sort of too much to do some of these demands can actually not serve them well moving forward.
Thanks, Ian. Let's go to the next slides. I know we are kind of running a little bit short on time. Just kind of quickly on this ripple effect. We've talked about this already. This traumatic exposure, even though it happens one time, it can keep recurring in terms of nightmares, in terms of thoughts. So we have to think about this negative psychological waves. They are called disaster ripple effect. We have to think about all the survivors that are involved in this and the fact that it can be prevalent long after the initial event has happened. This can affect us as clinicians, cause us to have that compassion fatigue I talked about. So it's important to have very healthy coping skills, have a social structure as a buddy system. Among the clinicians, it's important that if you're tired, you can't deal with it, you just hand it off. I think this is so important. We don't think about our own well-being as clinicians. And it's also important to have a structured, mandatory, non-mandatory debriefing sessions after an event, because it really helps make sure everybody is on the same page and to address anybody's unanticipated own psychological trauma as well. So next slide. And again, this is similar, just helping them cope. We talked about all this already. Most importantly, make them feel safe, pick a good time, limit exposure. This actually QR code here is from one of the resources that we share. If you want to have that QR code, this is going to help you kind of get a better sense of what these strategies actually do. We give you examples of how to do them and so on and so forth. And next slide. I think the next slide should be our resources slide, right? Yeah, and I think I want to just close with that. This is the list of resources that, in addition to what we talked about, again, cover some of the other things, including the one that I like a lot, which is how parents can actually talk to their children and help support them during exposure to a traumatic event. So yeah, thank you so much, everybody, for being part of our Fireside chat session. I hope we were able to share with you some of the thoughts and strategies around how children are affected in disasters and how to recognize signs and symptoms of PTSD, what we can actually do for them, what we can do for ourselves. And in about 1 minute, Ian, if you just want to add one best or two best advice you can have about how to speak to children about loss and grief before we close off.
I think to be available and to not have an agenda as much as try to get them to recognize what has happened in a safe setting and try to support them feeling comfortable and being available to them as they start to re-engage in activities.
Thank you so much again. Thank you, everybody, for joining us. Really appreciate having Ian's insight, especially on the neurochemistry of PTSD. In the next 3-4 minutes that we have, if there was any questions or anything that we can answer for you, please feel free to go ahead and put in chat. I don't know, Laura, Julie, if from the previous conversations sessions, if there's anybody that had questions in there that we can answer.
I did not notice any, Mo.
Okay, well, in that case, thank you so much. I'm going to pass it back to Julie for some closing administrative conversation.
And that was a great discussion. Feel free again, if you have any questions, put those in the chat. For physicians, nurses, and social workers, again, we are offering continuing education credits. You'll see this code KEXZEV. You are more than welcome to go to the ce.pedspandemicnetwork.org/code website and add that code in there for your credits. And then as before, the session evaluation, this is the QR code here on the screen. If you are unable to use the QR code, I put the link in the chat. Go ahead and click on that link or open the survey, complete that, and then we'll be happy to get you your CEs. Even if you don't want CEs, please fill out the session evaluation. It really helps us as a QI collaborative. We are all about QI and how do we improve our own internal quality. So we've used a lot of the session evaluation feedback, and so it's very helpful. So go ahead and fill that out. And with that, I thank the speakers for all of your time and your expertise and sharing your knowledge. Thank you to the participants for joining us today. And whenever you are ready, you can log off and have a wonderful day.